Molecular classification of endometrial cancer, uh, mainly used in adjuvant therapy decision making after the surgery is done. So, after the surgical staging is done. So, that does not mean it is out of the domain of a surgical oncologist. We have to know the basics of this molecular classification and its therapeutic implications to know whom to refer the patient to and to be able to make scientific decisions in a tumor board. So, in a nutshell, endometrial cancer right now is undergoing what breast cancer underwent probably 15, 20 years back. We all know that for the first time in the 2011 St. Gallen Breast Cancer Consensus Conference, breast cancer was recognized as three different cancers of luminal type, triple negative, and HER2 positive. Very similarly, the Cancer Genome Atlas project uh, recognized that there are four molecular subtypes of endometrial cancer. Subsequent retrospective studies, which had already been done to evaluate adjuvant therapies in endometrial cancer, they did a subset analysis and they proved that these molecular classes, the molecular subtypes, are prognostically different. They behave differently. They behave like different cancers, just like the way a luminal breast cancer behaves different from a triple negative or a HER2 enriched breast cancer. It was realized that the molecular classification of endometrial cancer also has a prognostic and a predictive role, which means it has a value. It has a prognostic role in that it conveys some prognostic information, whether the prognosis is going to be good or bad or intermediate, and also is a predictive factor in that specific treatment alterations and specific responses to therapy can be expected. Um, this is the ESGO, Estro bar ESP guidelines. That's European Society of Gynec-Oncology, European Society of Radiation Oncology, and European Society of Pathology consensus guidelines for molecular classification. And this is the European Society of Medical Oncology, ESMO guidelines. It has to be remembered very, very clearly that only in these two classifications, only in the ESGO Estro ESP guidelines and in the ESMO guidelines, molecular classification is included in the adjuvant therapy decision making risk stratifications. In NCCN guidelines, even in the latest NCCN guidelines, it is not included. This is the latest NCCN guidelines as of July 2025. Nowhere do we see molecular classification. Yes, in the NCCN manual, we'll find a page on the usefulness of molecular classification, but that has not creeped its way into the guidelines per se. As on date, as of July 2025, all the evidence that is accumulated for the therapeutic implication of molecular classification is retrospective. There is no prospective evidence to support the therapeutic implication of molecular classification. So that is why it has not creeped its way into the NCCN guidelines. And important points to remember, very important points to remember. The ESGO guidelines came in 2020, the ESMO guidelines came in 2022, and the latest NCCN guidelines of 2025. All the three use FIGO 2009 staging system for endometrial cancer. But in 2023, after the publication of the ESMO guidelines, ESGO guidelines in 2020, ESMO guidelines in 2022, after the publication of these two, FIGO has updated a staging system for the endometrial cancer with lots of changes. As with any cancer, advanced stages are not much changed, but the early stages, stages 1 and 2, that is the uterus confined disease, lots of changes have come up. So we'll be discussing in detail the reasons for such changes in the FIGO 2023. And the most important point to remember is that when in a tumor board, when the decision about adjuvant is being taken based on either ESGO or ESMO or NCCN guidelines, when we say 1A, we mean 1A of FIGO 2009, not FIGO 2023. The pathologist might have reported FIGO the cancer based on the 2023 updated staging system. Let that be the patient's stage. We can write on the case sheet, this is the patient's stage as per FIGO 2023. But while deciding adjuvant, that particular tumor factor has to be translated into the FIGO 2009 staging system. So, for example, a tumor uh, involving less than half of myometrium is 1A2 as per the 2023. It is just 1A as per FIGO 2009. This has not changed in the particular example that we discussed. It has not changed, but For example, aggressive histological types confined to the endometrium. So that is 1C. Aggressive histological types with any myometrial invasion is stage 2C. This is a very, very important point to remember. In the FIGO 2023, aggressive histological type with any myometrial invasion is stage 2C. Aggressive histological type also involves grade 3 endometrial cancer. So, for a grade 3 endometrial cancer that involves less than 50% of myometrium, it is stage 1A as per FIGO 2009, stage 2C as per FIGO 2023. So we cannot take the adjuvant decision based on the stage of 2C. We have to take the adjuvant decision based on stage 1A. Why? Not just because the guidelines say so. All the evidence, you know, that we all know that the guidelines are built on evidence. All the studies and all the evidence based on which these guidelines are formed have used the FIGO 2009 staging system. So this FIGO 2009 is the language spoken in this ESGO, ESMO, and the NCCN guidelines. So we cannot speak two different languages for the same patient. That is the basic crux I'm trying to say. We cannot use a FIGO 2023 staging system and then say we'll make decision based on this staging, this guideline or this guideline or this guideline. So then coming to the adjuvant therapy, in I would proudly say that all the information that is required for the adjuvant therapy decision making based on all these, this or this looks such a complicated table, right? Or this is given in this single table, where without molecular classification adjuvant therapy decisions can be easily made. 1A low grade is low risk, 1A high grade or 1B low grade. Just adding one each is intermediate risk. Adding both risk factors, 1B with high grade or the presence of substantial LBSI or the presence of stage 2 cervical stromal invasion is HIR, and anything above stage 2 is stage high risk. That is nodal metastasis or bladder or bowel mucosa involvement is high risk. So for high risk cancer, so for any cancer, the decision about avoiding adjuvant or changing adjuvant is only for early stage cancers. If you understand, we will not be asking for an oncotype DX for a patient with a locally advanced breast cancer. Only for an early breast cancer that is hormone receptor positive. So meaning we avoid adjuvant using an oncotype DX. That is the thinking. So high risk cancers are usually not affected by all these molecular subtypes. So anything that has already spread to the nodes will definitely require systemic therapy. Will definitely require adjuvant EBRT. There's no doubt about all these things. So the question is this: the molecular classification is very useful in these groups of patients. So if you see the ESGO guidelines, we all know that there are three main molecular subtypes. One is pole mutated. The first step is pole mutated. For all patients, we get a pole mutation testing. If that is if that is mutated, the patient is pole mutated straight away. If that is wild type, the next step is MMR. If it is MSI high, if it's MSI high, and if its last step is if neither pole is mutated nor is MSI high, then we get a P53, and that can be mutated or wild type. If P53 mutated, the patient is P53 abnormal. If that is also wild type, so patient is pole negative, MSI stable, and P53 wild type, then becomes no specific mutational profile, NSMP. If you notice in this table, so MSI high is always clubbed with NSMP. So which means MSI high per se does not change the risk stratification of the cancers, whereas pole mutation and P53 can either upstage or downstage the risk stratification. So this is what is meant here. Pole and P53 are like game changers. They can upstage or downstage. Then why to do MSI high? If only P53 and pole are very important, why to do MSI high? That is because of this concept of multiple classifiers which are present in 5%. So imagine if we do only pole and P53, which are the game changers, and don't do MSI, if the patient is P53 mutated and MSI high, we would have taken it as, if we had not done MSI, we would have taken him as P53 mutated, her as P53 mutated. But If the patient is P53 mutated and MSI high, the patient should be taken as MSI high. So that is why in the promise sequencing, it always starts with pole mutation. That supersedes everything else. If pole is mutated, it supersedes everything else. The patient become a low risk, especially in stages. We are talking about uterus confined disease, stages 1 and 2. So that's another important point to remember, that it does not change anything for stages 3 and 4. We already discussed that for high risk cancers, stages 3 and 4, we are not going to avoid adjuvant just because pole mutation is there. There is not enough data to support that. So we get MSI just to rule out a multiple classifier. So patient can be P53 mutated, but if she is also MSI high, then the patient's MSI high status supersedes the P53 mutation. Now the final crux. I'm also proud to say this in one slide. This may look like an oversimplification, but in this one slide, the entire concept of molecular classification based adjuvant therapy decision can be made. This is more than enough for surgical oncologists. So we saw from this slide is just a comparison of, it's an extrapolation of the previous slide with the molecular classification. So we saw in this that 1A low grade is low risk, right? So how is the molecular classification going to change it? If you observe a pattern, I've written it did like this. All the patients. That is the promise sequencing. First get a pole mutation. If pole mutation, it is pole mutated. We need not even look at the other two. If pole is wild type, then we get an MSI. If it's MSI high and P53, whatever it is, if it is MSI high, right? So if neither pole is also wild type, MSI also stable, then P53 we check. If that is mutated, then the patient becomes P53 mutant. For example, there is a fourth row. This is also normal. If this is also wild type, that is no specific mutational profile. Absolutely, molecular test has not added any information to our original conventional histopathological risk factors. So we see we saw that for low risk patients, no adjuvant is required. For intermediate risk, our main concern was vaginal vault recurrence. We need IVBT. For HIR, our main concern is pelvic nodal recurrence or paraortic nodal recurrence. So we use EBRT. So any patient with LVSI, lymphovascular space invasion, meaning lymphatic vessels are invaded, blood vessels are invaded, so has a high chance of lymph nodal mets and distant mets. So in such patients, we need systemic therapy, right? It's common sense. So for in HIR, we use EBRT plus or minus systemic. Anything more than that, always definitely systemic is required because already nodes are positive or it's a locally advanced disease. So now, as I said, our molecular classification is only going to change stages 1 and 2. No changes occur in the stages 3 and 4 because they are already advanced. Always chemotherapy is required. Now let's come to the stages 1 and 2. Stages 1 and 2 we saw are till here. All these three boxes are stages 1 and 2. Now, if you see an beautiful observation, in 1A, we were going to observe the patient, right? We were not going to give anything. Just observe that. In 1A low grade, that is low risk strata, we were going to observe. So this side till this line is the old school without molecular risk stratification. This side of the box is with molecular stratification. So with molecular stratification, what happens is if the patient is P53 mutant, without the other two, the patient becomes an intermediate or high risk. So we have to give adjuvant. So without molecular classification, we would have observed this patient. But with molecular classification, if P53 mutation, we identified someone who would benefit from adjuvant therapy. So this is how molecular profiling has changed the adjuvant management. We were going to observe if pole is mutated, anyway we have to observe it's a low risk tumor. If MSI high, anyway it does not change. As I said earlier, MSI high, just isolated MSI high does not change the stage of anything. It's always MSI high and no specific mutational profile are always clubbed together. MSI high per se does not change anything. It is not a game changer. We get it done to rule out a multiple classifier. So it was a low risk. If pole mutated, again low risk, observe. Again, in this particular group, why do we get a pole mutation? We were anyway going to observe. Why did we get a pole mutation? So imagine this patient. Imagine this patient very carefully. A 60 years old female underwent a surgical staging. The final histopathology is less than 50% myometrial invasion, low grade, no LVSI. The patient is originally conventionally classified as a low risk group. Now we decided to observe, but the patient is willing for a molecular classification. We get all this done. So why can't we just get P53? And if it is mutated, we'll give adjuvant. If it is wild type, we will observe. We cannot do that again because this patient may be a multiple classifier. So if the patient is a P53 mutant with the MSI high, there's no benefit from adjuvant. She's MSI high because that supersedes. If it's a P53 mutant with the pole mutation supersedes. So observation only. So that is why it is imperative to get all these three done. And that is why this sequencing is important. That is why it is always pole mutation first. If that is positive, if mutation positive, it is pole mutant. Period. Done. Dot. Full stop. If that is negative, the second step is MSI. If MSI high, P53 need not be done because it is MSI high. Full stop. If this is also wild type, this is also low, then P53 will play a role. So that is why we got all these three in this particular patient. So in this patient, in the low risk, in the original conventional low risk strata, the only thing that can change the management is if the patient is an isolated P53 mutant, which will require an adjuvant. Now, the second class was intermediate risk. So that is either 1A with high grade or 1B with low grade. We wanted to avoid a vaginal vault recurrence and we decided to give IVBT. This is without the this line, this side, it is without the molecular classification. Now, with molecular classification, first step of molecular classification is pole mutation. If she is pole mutant, she becomes a low risk. An intermediate risk has become a low risk and she can be observed. MSI high, not a game changer, will not change the risk stratification for any patient. So, intermediate continues to be intermediate, receives IVBT. If it's neither pole mutant nor MSI high, isolated P53 mutation makes her high risk. An intermediate risk has become a high risk requiring systemic plus EBRT. Correct? So without the without the molecular classification, intermediate risk that has become either low risk, that becomes a low risk if pole mutant, continues to be intermediate risk if isolated MSI high, becomes a high risk if P53 mutant. Very similarly, the next strata was HIR, either 1B with high grade or presence of substantial LVSI or the presence of cervical stromal invasion. So this was HIR, high intermediate risk. To prevent pelvic nodal recurrences and para-aortic nodal recurrences, we need EBRT plus or minus systemic therapy if the patient has LVSI, right? Substantial LVSI. So in HIR, our original plan without molecular classification would have been EBRT plus or minus systemic. Now, first step of molecular classification, we did a pole mutation. If pole mutant, period, dot, full stop. Observe. So, a patient who would have received, for example, a patient with a 1B high grade tumor, a 60 years old female who underwent a surgical staging, final histopathology is more than 50% myometrial invasion, high grade. Say, let's say substantial LVSI is also present. All the high risk features are present. She becomes a high intermediate risk. Original plan would have been EBRT plus systemic in this patient. She would have received so much. Now we got an we got a molecular classification. She turned out to be a pole mutant. We can just observe her. That's the beauty of molecular classification. So we know she's going to behave extremely well. Her recurrence rates are very low, so that is why we don't have to do anything. So definitely we can observe her. So this is based on retrospective data from PORTEC 3A analysis. Ongoing trials will further validate this, but at present all guidelines recommend observation for this group. Now, isolated MSI high. Pole for the second step of molecular testing was pole is wild type. After pole wild type, MSI high MSI testing we dot. If MSI high, it's MSI high. Then in that patient, MSI high not being a game changer, continues to be high intermediate or HIR, continues to be the same treatment. So if you remember, isolated MSI high retains the same risk stratification. Low risk remains low risk, intermediate risk remains intermediate risk, HIR becomes HIR. Pole mutation down stages. Low remains low because it is already low. Intermediate became low, HIR became low. P53 up stages. Low became intermediate or high, depending on degree of endometrial myometrial involvement. Intermediate became high, high intermediate became high. So you should not confuse HIR with high. High is the last risk. This is the last. So so that is why if pole, those are the third step of molecular testing. For in this patient, for first we got pole mutation negative, unfortunate, pole wild type. Then we got an MSI low, that is MSS stable, microsatellite stable, unfortunate. Then we got a P53. If this was at least wild type, she would have remained known specific, no specific mutational profile. She would have remained HIR, but now P53 is mutated, upstages the disease to high risk. So she will definitely require systemic. All P53 mutant cancers are almost always serous, high grade, high chances of lymph nodal metastasis. They require some form of systemic control, so systemic therapy. So in one line, in low risk, pole mutated remains low risk. Low risk MS isolated MSI high, not a game changer, remains low risk. Low risk isolated P53 mutant becomes intermediate or high, needs adjuvant. What would have been observed now is giving adjuvant. Intermediate risk can become low risk if pole mutated, can become high risk if isolated P53 mutation, will remain the same intermediate risk if the non game changer MSI high, isolated MSI high. HIR can become low risk if pole mutated. HIR can become high risk if isolated P53. HIR continues to be high risk. HIR if isolated MSI high. So in this one slide, we can have a complete overview of the molecular therapeutic implications of the molecular classification of endometrial cancer and how it has changed our therapeutic decision making, adjuvant decision making. There are some important points to remember that all this data is retrospective. Encouraging patients for enrollment in clinical trials is very vital, and ongoing trials like POTEC 4A, Rainbow clinical trial program, all that will shed a lot of light into this evidence. So basically, as I said, in 2011 in the St. Gallen conference, breast cancer was recognized as three different cancers. Probably a few years down the line, this will also become the global standard of care. Until then, all the guidelines recommend, if feasible, if possible, get molecular testing done. None of the guidelines say that molecular testing is mandatory, but it is imperative to get it done because this is the future, this is the way ahead.